Okay, chapter 28 has to do with angina and chest pain. Just remember that all chest pain is not from an MI. It can be from many other things, pneumonia, pulmonary embolism, GE reflux. So you may see that, not a trick question, but kind of gearing you toward knowing that you need to look for other things besides just an MI. Sure you've seen all these before, so we're just going to kind of click through them. You need to know everything that's on the slides, but particularly things in red. Anytime you have anything cardiac, lifestyle changes, reducing sodium to 2,400 milligrams daily, that's the DASH diet. That's something that you need to know. I did want to go back to one thing. If you have a patient and they're at high risk for developing significant coronary heart disease, those are patients that already have class 3 angina. Just so you know, I'm trying to find out where that was though. Once you're at class 3 angina, you're going to have significant coronary artery symptoms. And it's not here for whatever reason. Let's see, no matter what class of angina anybody's in, you're always going to give that 81 milligram to 325 milligram aspirin to. That's all patients, no matter what class. Also, anybody who has angina, regardless of the class, it's diabetic, will always have an ACE inhibitor. But as you know, you've seen before, all diabetics pretty much have an ACE inhibitor. And remember all those benefits of the ACE inhibitor. So once again, whose nitrates are a good choice for who? Patients with hypertension and heart failure. Okay, so your patients with angina, and you saw the different classes and what meds to give. This is how to take nitro, but actually, I'm trying to find let's talk about the beta blockers first. Beta blocker is also part of their treatment plan, especially if they have an exertional angina or they have any kind of arrhythmias / dysrhythmias. Okay, and let me go back to the how to take the nitro, because this is an extra sidebar slide, so you must need to know this. You're going to have 1 tab or 1 spray. First sign of chest pain. You can repeat every 5 minutes, not to exceed 3 doses. If your patient does that, you need to call the hospital and they need to go. And as far as isosorbide goes, I know we've talked about how to dose that, and that it needs to be that 12-hour rest period, so they need to take it at 7 a.m. and 2 p.m., not your normal BID, to prevent the nitrate tolerance. That goes on. And ACE, we've talked about that. And aspirin and statins, we've talked about that. Okay, once again, all patients, no matter what class, get 81 to 325 milligrams regardless of the class. So the classes are also listed in your book, but here they are. And you'll be able to class your patients, group your patients by their symptoms. As you can see in class 3, they have chest pain during routine physical activity, marked limitations of ordinary activity. So a class 3 of a high risk for developing heart disease, significant heart disease. Okay, so why ACE? Once again, recommended for all symptomatic patients with chronic stable angina to prevent MI or death, to reduce symptoms. All diabetics, regardless of class, should be on an ACE. So now we can see why we need to control the diabetes. It's run us into hypertension, it's run us into angina, it's run us into CHF. Okay, we use a lot of combo drugs and multi-drug therapy. So combinations of these long-acting nitrates and a beta blocker, they're safe to use together and they're cheaper. But what's an added benefit? Their adverse side effects cancel one another out. So you'll see that often where you have a long-acting nitrate and a beta blocker together. And something that's I don't think we talked about at all too much in any of these slides at all is what's the biggest increased risk for MI in a woman? And right now, that's just totally estrogen replacement. So that's why that's such a controversial area during menopause. Do we use it or not? Causes MI, but yes, we know it's bone and cardiac protective at the same time. Okay, you have your cost. Whenever you're dealing with the cost, you want to you have to understand that most of these patients require multiple drugs, so it's going to be pricey. They're usually all older adults on fixed income. There's not a lot of, there is lack of drug selectivity, and can result in increased adverse reactions. But we always want, and you want to pay attention to generics. And the generics in these drugs, because these are older drugs, they're usually bioequivalent, and they're really great drugs. So you don't have to worry too much about that. The patient should be able to get what they need. And your initial assessment, just make sure you know all of these. Okay, and when are you going to refer out? You're going to refer out when you have chest pain that you can no longer handle. Post-MI, and they all of a sudden have a new chest pain, when all of your standard therapies are not working, when they're not having improving exercise tolerance, that's when it's time to totally not treat in primary care at all. I think anymore, most of us would send the patients off to cardiology when they became even if they're stable, but it's really, really a chronic problem.